Good afternoon and greetings from Singapore. I am Lo Ngai Nung and I'll present on the impact of increased BMI on our practice of knee arthroplasty. My disclosures, and this is not relevant to today's topic. In today's global session 3 analysis of our practice, we will touch upon what we know of increased BMI and its effects on the practice of knee arthroplasty. We will look particularly at the outcomes of knee arthroplasty, comparing Western versus Asian literature. And we'll ask ourselves, do patients change their BMI after knee replacement? And how about outcomes in the high BMI patients after unicompartment replacement or patellofemoral replacement? Now, we know that obesity is a robust risk factor for knee osteoarthritis, and this is well shown both in Western and Asian studies. There is obviously an evidence of mechanical cause for knee osteoarthritis, with high BMI leading to initiation and progression of knee osteoarthritis, and with patients having a higher risk of undergoing knee replacement surgery. We also know that obesity is associated with poorer clinical outcomes after knee replacement in terms of pain, function, and complication rates. In particular, the risk of infection increases as the BMI increases. Patients with BMI more than 40 would carry a 3 times higher risk for periprosthetic joint infection. For these patients, the risk of knee replacement must be carefully weighed against the benefits. So considering all this in mind, then should we offer the high BMI patients joint replacement surgery? And in this landmark paper published in 2017 in American JBJS, the authors conclude that obesity should not be a deterrent to undergoing joint replacement, as the functional gain in obese patients was similar to that experienced by the non-obese. And in fact, pain relief was greater among the more obese patients than the other weight groups. So what about out here in Asia? Well, our studies here published in Singapore which show that outcome following knee replacement arthroplasty among Asian patients are comparable between the two groups, and obesity does not imply poor outcomes. In this paper from our institution, a 10-year follow-up study looking at the influence of obesity on functional outcome and quality of life after total knee replacement, we found that both groups, the obese and the non-obese, would have high satisfaction rates and fulfillment of expectation at 10 years. And although both groups of patients have significant improvement in function and quality of life post-surgery, the obese patients tend to have smaller improvements in their functional outcome scores. Hence, it's important to counsel patients on the importance of weight management so as to achieve a more sustained outcome after knee replacement. Now, it's often assumed by patients that weight loss will occur after the knee pain is relieved by the replacement surgery, and hence breaking this vicious cycle of obesity leading to knee pain, leading to poor function, mobility, and further weight gain. Unfortunately, this assumption is not true, as shown by our studies that the majority of the patients actually maintain their BMI after knee replacement surgery, while a significant proportion, 21%, gained in BMI. Fortunately, the BMI gain did not affect functional outcomes, nor did it affect the 10-year survival rate. How about the bilateral simultaneous knee replacement? Is it worthwhile offering it to high BMI patients with the same idea that it may improve their functional status and mobility and help manage their weight better? And again, unfortunately, our papers show that 59% maintain their weight, while another 28% gain weight after the bilateral knee replacement, with the older patients with the high BMI being more likely to gain weight. What about unicompartment replacements and the influence of obesity on clinical outcomes? Well, both the obese and the non-obese will experience significant improvement in clinical outcomes 10 years after surgery. However, obesity in this paper from our institution shows that it's a significant predictor of lesser improvement in outcome and increased revision rates at 10 years. Very little literature is available on patellofemoral replacements. And in our study, we found the same thing, higher body mass index BMI leading to lesser clinical improvement and higher remission rates after PFR because of progression of the tibial-femoral osteoarthritis. So in summary, we conclude that both high BMI and normal BMI patients will benefit from knee replacement surgery, but the high BMI patients tending to have smaller improvement. On the contrary, we found that patients maintain or gain weight after knee replacement. Fortunately, the BMI did not affect the functional outcome or remission rates. For UKAs and patellofemoral replacements, high BMI patients have poor outcomes and higher remission rates at 10 years. Thank you.